Good afternoon and welcome to today's IAC webinar, Continuous Quality Improvement in the Echo Lab, How Do We Walk the Walk? My name is Kelly Baer and I am the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime throughout the webinar, as we will monitor questions throughout the presentation and try to answer as many of them as possible during the Q&A period. Also on the left sidebar, please note the Resources tab. Click on this tab for a link to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the ASE CEU credit, you must be registered, logged into this webinar, then complete the survey. The survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. This webinar is a joint presentation of IAC, SOAP, and ASE. And now I would like to introduce today's guest presenter, Dr. Anitha Parthiban. Dr. Parthiban is a board-certified pediatric cardiologist and director of the echocardiography laboratory at Children's Mercy Hospital in Kansas City, Missouri. She's also an associate professor of pediatrics at the University of Missouri Kansas City School of Medicine. Her clinical and research focus is in the area of echocardiographic imaging in congenital heart disease with expertise in 3-dimensional and fetal echocardiography. A true expert in the field, and we are happy to have her with us today. And with that said, I will now turn this webinar over to today's speaker, Dr. Anitha Parthiban.
Thank you very much, Kelly, for that introduction. I'd like to thank the IAC, SOAP, and ASE for the invitation to present this webinar today. It is indeed a great honor. I have no disclosures relevant to this presentation. So for this talk today, I'll first start with going over some of the quality metrics we could be tracking in our echo labs. Then I'll walk you through some of the basic principles of QI science using an example of a project we completed at CMH a few years ago. I'll wrap up with sharing with you some of the practical strategies that we have applied at our lab at Children's Mercy to successfully improve our quality and performance, and finally, some thoughts about future applications. So what quality metrics should we be performing? In general, quality metrics should be aligned with the Institute of Medicine's framework for quality measures in healthcare that are shown in this diagram. The 6 domains in this framework are safety or avoiding harm, effectiveness, which could be keeping with the accepted standards and guidelines, patient-centered care, timeliness and reduced wait times for care, efficiency by eliminating waste, and lastly, equitable care. Most QI metrics that we commonly use address safety and effectiveness. Nevertheless, the others are equally important. And all of us are familiar with the MACRA legislation from a couple of years ago, which is a bid to overhaul and modernize the way healthcare providers report information necessary before getting paid. With a goal to reduce the burden of healthcare costs to American taxpayers, MACRA is designed to help providers report data on the quality of services. And as you all know, the healthcare environment is moving towards a focus on value rather than volume, and very appropriately so. So what about quality data and echocardiography? Do we have any? In this recent study of practice variations among pediatric labs, 47 of 85 pediatric echo labs surveyed responded, and the vast majority were academic institutions. The study showed significant variability among institutions regarding the scan protocol, acquisition methods, including the color scale settings, and function measurements reported. So there exists an opportunity for us to revisit and develop some new standards for pediatric echo labs, perhaps including a guideline document for quality operations. How about adult echo labs? This was a study that looked at variation in reporting of mitral regurgitation. So as you all know, clinical outcomes after surgical treatment of mitral regurgitation are worse if intervention occurs after deterioration of the LV size and function. And transthoracic echo surveillance is critical in the management of this lesion. Substantial variation in follow-up intervals for TET assessment of mitral regurgitation were noted in the study, despite adjusting for patient variables. And these were because of provider factors. So on one hand, not ordering the echo frequently enough could put the patient in jeopardy, whereas over-frequent ordering can impair patient access and reduce value. So there certainly is some room for us to decrease or minimize practice variation. Next, I'd like to review some of the existing quality metrics in the area of echo. The ASE has published guidelines and standards for echo lab operations in 2011. And in this document, the authors recommend QI as an integral part of echo lab operations. In addition to lab standards, from the operational standpoint, the ASE guideline document recommends specific measures for quality improvement in the echo labs. These include tracking overall and individual procedure volumes, compliance with the protocol with a recommendation of 5 to 10 studies per provider reviewed annually with greater than 90% compliance recommended, a process to measure and address inter-reader variability with at least 2 studies per quarter per modality being reviewed, and documentation of measured EF in the report with at least 90% of the studies having a measured EF reported. In addition, in this document, the authors also recommended cross-modality comparisons for accuracy with at least 4 studies per provider for each modality being reviewed every year, and metrics around communication, including timeliness of the report and a process for reporting critical results. In addition, they recommend process to track patient throughput and address any delays, and there should be documentation of the provider performance and progress. And of course, as part of the accreditation by IAC, labs are required to perform and document QI as part of the accreditation process. The metrics recommended by the IAC are very similar to those listed in the ASE guideline document I just talked about. And these include assessing the completeness and quality of the study and the report, the measurement variability between readers, and correlation to other modalities for diagnostic accuracy. The IAC also offers a free QI self-assessment tool, which is very useful and helps labs have an internal benchmark and identify opportunities for improvement. If you use this tool for your QI, you will meet the QI requirements for accreditation. In addition, it satisfies other quality initiatives like the MOC points and also the merit-based incentive payment system. And can accreditation improve quality? There are a few studies that have looked into this. This is a retrospective study comparing quality metrics in 236 pediatric echoes in patients with congenital heart disease. And they looked at 2 centers. One is a community hospital in California before and after accreditation. And the studies were compared to an accredited academic institution, the Lucile Packard Children's Hospital. And these were during equivalent eras. So So consecutive patients that required cardiac intervention were matched between the sites based on age, complexity, and the time period. And the authors found that there was an improvement in study and report completeness, but really in the time period they studied, no change in quality or diagnostic accuracy, and they recommended further studies to evaluate this. In this study, looking at adult labs compared with non-accredited labs, accredited sites more frequently reported anthropometric data, left and right ventricular size and right ventricular function. Accredited labs had higher rates of complete and diagnostic color and spectral Doppler imaging. And in fact, that improved the concordance between the external and internal readers. The American College of Cardiology, through the ACPC Quality Network, has also made available several non-invasive imaging quality metrics. There are at least 3 or 4 now that centers can submit data to, and several others on the way. And centers can learn from each other by comparing their performance, as well as through collaborative learning about what each center did to improve. I'll spend the next portion of my talk talking about some basic QI principles and signs. In this slide here, you see the model for improvement, which is the basis for quality improvement. And it involves asking 3 fundamental questions. The first question, what are we trying to accomplish, relates to the aim statement. The second, how will we know that change is an improvement, relates to the data collection or measures. And the third, what changes can we make that will result in improvement, relates to the interventions. Change in this model is implemented through PDSA cycles, or the Plan, Do, Study, Act cycles. So let's walk through an actual project that we performed here in our institution. Like every QI project, it was born out of a problem, and our problem was that our patients were waiting very long in the downtown cardiology clinic for their echoes. This caused a backlog of patients in the clinic rooms, and some patients ended up anecdotally waiting for over an hour. And obviously, this caused a lot of patient and parent dissatisfaction, and the clinic providers were also unhappy, and overall, there was poor cardiology clinic throughput. So where do we start? It is important that we first assess the problem and refrain from jumping to solutions. So the very first step here is to form a team of key stakeholders. Remember, you cannot make changes where you have no influence. So for our team, we had sonographers, echo readers, the clinic docs, as well as the clinic charge nurse, and a representative from the EKG team as well. And I always put some thought into who to ask or get into the team. Of course, we have the gung-ho, energetic volunteers, but I also try to include 1 or 2 Eeyores or naysayers who know will be a little grumpy about change. And these folks are good because they add some perspective to the project, as well as if you convince them, then half your work is done. So it's well known that every process is perfectly designed to get the results it gets. So from these sets of traffic signs, it's clear which one is most likely to get you to your destination correctly and efficiently. And before making a process change or implementing solutions, it is very important to understand your current process. Edward Deming, who's considered the father of QI, said, if you cannot describe what you're doing as a process, you don't know what you're doing. So how do we do that? We did what's called a Gemba walk. Gemba is derived from the Japanese term gembitsu, which is used to describe the observation of work where the work is actually happening. So to do the Gemba, our sonographer followed 15 patients from the time they checked in to the start of the echo and documented all the processes in between. And you can see there are multiple steps involved, and only a few of them are actually seen by the patient. Such a process map can be very helpful in identifying opportunities for improvement. In this process map, we have indicated all the possible delays by these red stop signs. I won't go into the map in detail, but what we did find was several non-value added processes that could be eliminated. And when you ask, why are we doing this? Why are we doing all of these steps? The answer typically is because we've always done it this way. And I'm sure you guys have come across such a situation frequently as well. And we are just loath to change what we are always been used to. So let's go back to the model of improvement and ask the first question. What are we trying to accomplish? In other words, what is the aim of this project? For quality improvement or performance improvement, it's very important that we have a SMART aim. And what this refers to is that your aim should be specific, it should be measurable, it should be achievable, meaning within your scope to accomplish. It should be relevant, meaning it makes sense to the job function you perform. And finally, it should be time-bound. So going back to our project, our SMART aim was by July 1st, 2014, 90% of outpatient echoes in the CMH downtown clinic will start within 20 minutes of echocardiogram order initiation. This is opposed or in contrast to a general or global aim that would say, we want to improve timeliness of care delivery to patients in the cardiology clinic. So you can see the difference between a SMART aim and a more general or global aim. Now that we have the aim statement, we ask the next question. How will we know that a change is improvement? In other words, what are we going to measure to know if we have improved or not? Measurement or data collection is key because if you cannot measure, you cannot control the problem and you cannot improve it. As Deming said very wisely, without data, you're just another person with an opinion. It is, however, very important to note that the measurement for PI or QI, whatever you want to call it, is very different from research. For research, we collect large amounts of data and control for as many biases as possible. And we often blind the observer to remove bias. In QI, though, we perform small tests and gather just enough data to know if there has been an improvement. It is important to be more practical rather than a purist and think of every possible scenario. It's very important to consider the scope of the project because a frequent reason why QI projects fail is when data collection is too burdensome and not thought out or planned well. So for research, it can take a long time to obtain results, whereas for process improvement, it's all about very small and frequent sequential tests of change. So what are the types of measures? So there are three different types. The first is the outcome measure, which is measuring the primary outcome or what you want to achieve from your project. In other words, the result. The process measures look at the working of the processes that will drive the desired outcome. And balancing measures measure any unintended adverse consequences to other parts of the system. So going back to our project, our outcome measure was the time in minutes from the time the echo order was activated in the EMR to the start of the echo imaging, which we chose to be the time that the first clip was acquired. Now, we chose this because it could be easily pulled electronically and retrospectively rather than us keeping a time chart. Technically, it's not perfect because it included the time taken up to set up the patient in the room. Nevertheless, it was a good surrogate measure, and we chose it for the convenience. So your measures don't have to perfectly reflect what the data you're trying to get, but it has to be close enough. For process measures, we looked at several aspects such as the echo room utilization, the number of echoes performed per sonographer, the start time and end times, etc. For balancing measures, we thought about things such as, can our focus on efficiency end up in causing a decrease in quality of our echo? Or could there be delays to other aspects of clinic flow because of our project? So those were our balancing measures. So now that we have our process laid out, our aim statement, and we know what we will measure, we get to the third question in the improvement model, which is what changes can we make that result in improvement? So this relates to the interventions that we are going to implement. So one way to know what interventions we are to implement is by going back and looking at our process map and identifying the opportunities for improvement. So here's the process map that we had designed for our project, and the red stop signs indicated the various redundant steps or steps that cause delay. So then we could design our interventions or our countermeasures to address those delays. Another commonly used method is called the Failure Modes Evaluation Analysis, or FMEA. This is a slide I've borrowed from Christopher Statiel at Cincinnati Children's Hospital, and this shows an FMEA type of process map that they did for the inpatient workflow. In the middle are the various steps involved in their inpatient workflow, and in the red below are reasons why the process failed. And they track the most common reasons for delay in turnaround of inpatient reports and accordingly design the interventions for their study. So this is a type of map, a process map that we can use called the FMEA, or Failure Modes Evaluation Analysis. This slide shows a key driver diagram. So in the driver diagram, the middle column shows the key drivers of our desired outcome being in our aim statement. The interventions are in the column all the way to the right. The red star indicate interventions that we felt could have had a high impact and within the scope to implement. For example, we could eliminate redundant steps like walking billing sheets and orders back and forth. Even though the clinic and echo space were in physical continuity, they operated in silos, and communication between the two was suboptimal. The echo lab was not very aware of the schedule and challenges to clinic flow for a particular day, so we started huddles. Fortunately, a process became available through the EMR where our patients could be tracked from the time they were checked in to being checked out. And this was displayed on a computer screen in the clinic and the echo lab so everybody could be aware. We needed a traffic cop on either side to watch and regulate patient flow. We did not have an echo lab supervisor at that time, so we assigned a sonographer to be the traffic cop or charge person for the day, while their counterpart would be a clinic charge nurse. And then it became clear to us that space and room utilization was a problem. So there was a mismatch between clinic and echo rooms. So we repurposed one of the clinic rooms as a fourth echo room. We outsourced other outpatient echoes like the renal patients to a different site. We went to the kidney center to do those studies. This also had the effect of improving care for our renal and dialysis patients because they did not have to shuttle back and forth. And we now use this model of care for our cancer survivor clinics, our muscular dystrophy clinics, and other clinics, which has been a great patient satisfier. So then when we come up with multiple possible interventions, how do we know which one to pick? The Pareto rule can be helpful in this regard, which is simply this. 80% of a problem is typically caused by 20% of the possible causes. In other words, if you can identify the top or most frequent 2 to 3 causes of the problem and design the interventions to address them, then we are likely to have a greater impact. Another tool that could be helpful to pick the appropriate intervention is what's called a prioritization matrix. In this matrix, the ease of implementation is weighed against the scale of the impact, and the ideal intervention would be fairly easy to implement with high impact, whereas something that is hard to implement with low impact would be discarded. So for our project, we chose the interventions with the highest impact, as indicated by the green stars. Some were easy, such as huddles and having a consistent early start each day, whereas others were tougher to accomplish and required some negotiation, like repurposing a clinic room as an echo lab room, but still very much worth the effort. On the other hand, changing to a schedule-based lab would have met with a lot of resistance and caused unhappiness among our cardiology colleagues, as well as hardship to our patients that travel several hours for their appointments. So we decided not to pursue that. Finally, interventions in the improvement model are implemented in the form of PDSA, or also called PDCA cycles, where we first assess and plan, then implement. We then study to check the effect of the implementation by collecting data. And finally, we act upon that data to either adopt it if it worked well, or adapt it with some changes if it was not quite perfect, or abandon if it did not work at all. And the concept is that through a series of iterative, smaller scale PDSA cycles, larger scale change can be achieved. So this slide shows the results of our project. Data for QI projects is often presented as control charts, but I'll show you later that it can also be made quite simple. This is a process control chart for a project. On the x-axis is the timeline of the project in weeks. On the y-axis is the average echo wait time in minutes. The timing of the various interventions is indicated by the arrows. The yellow line, or the center line, shows our average wait time, which you can see pre-intervention was close to 25 minutes, and at the end of the project was closer to 15 minutes. Now, that does not seem to be a dramatic difference, but if you looked at the red lines above and below the center line, you notice that they are now much tighter post-intervention, indicating that our process is more predictable and less variable. So to summarize, some key aspects we want to consider when launching a QI activity are: first, we need to ask the question, is the activity adding value to the patient care? Is it a real need versus a pet project that somebody conceives in a conference room? The project should have a smart aim, as I explained before. The outcome and process measures should be well defined. And again, I will say this again, one of the common pitfalls is not defining the scope of the project and getting overwhelmed by the data burden. Again, with QI projects, we don't have to worry about statistical power, but rather focus on demonstrating smaller scale continuous improvement. And finally, our interventions are ideally small scale, specific, and implemented sequentially. So it's all about having a well thought out strategy and taking small steps. For the last few minutes, I'd like to share with you our journey in QI at the Children's Mercy Echo Lab over the past 6 to 7 years, and how we have transformed challenges into opportunities. To quickly provide some context regarding our lab, our annual volume is a little more than 19,000 echoes. We perform services at 11 locations, with 40% of the volume arising from outside of the main campus. We have 22 sonographers and 11 imager cardiologists. However, clinic docs read their own echoes outside of the main hospital. We have found that formal training in performance improvement is immensely helpful. Fortunately, this is readily available to us at our institution, and many in our team, including myself, have been through a course where we are coached through a QI project from inception to implementation. Over the last years, our hospital has adopted the lean system, and I'll talk a little bit more about that in subsequent slides. Just a few words about lean. It is actually a manufacturing term popularized by Toyota, and simply refers to an operating system that focuses on eliminating waste and reducing the time, effort, and cost it takes to provide a product or service, while ensuring high quality and reliability. What about waste in healthcare? In the USA, it is estimated that about $760 to $935 billion are wasted annually, which is about 25% of the total healthcare spending. In today's financial milieu, especially with the pandemic, we have realized that resources are not unlimited, and there's an even greater onus on us to be efficient and delivering high quality care. So healthcare waste has been classified into 8 types, and the mnemonic downtime is often used to describe them. So D stands for defects. In the Echo Lab, this may be a report or a study that does not have essential information for a patient's care. For example, the weight is entered wrong and the Z-scores are messed up. I think my pediatric colleagues can fully relate to this problem. O stands for overproduction, which is considered one of the most evil of all ways. So for example, doing a 200 clip 90-minute complete study on a patient where the question asked clinically was very focused and they already had a complete scan. Now we feel really good about the wonderful images we obtained, but it was more than what was needed and it was stressful for the patient and delayed others in the clinic or waiting for the echo. W stands for waiting, which is just as it sounds. Every time we wait for patients or we wait to read a study or patients wait for us, it is time wasted. N stands for non-utilized talent, which refers to performing tasks below your expertise level and thereby taking you away from value-added care. Transportation and motion refers to unnecessary movement of supplies or personnel back and forth due to a lack of standardized process. For example, having to walk back and forth between floors to access an echo reading station to put in your numbers. Inventory is supplies, and how often do we overstock supplies and then discard them because they expired? And finally, extra processing refers to extra steps that add no value to the patient. So at Children's Mercy, we have focused a lot on processes. And as Edward Deming, the father of QI, said, a bad system will beat a good person every time. So some of the things we've worked on is to improve efficiency and decrease waste. We worked on timeliness. We worked on improving reproducibility of our measurements. Improving our diagnostic accuracy, as well as the study quality and completeness, and similarly for the report, making sure our echo reports are comprehensive and accurate. So the way we have approached this is through several strategies that I've listed before, and I will show you examples of each. We've emphasized a lot on communication and huddles. Some of these occur at the huddle board, whereas others may be electronic. We use the daily management system, or DMS, which I will go into a little bit more detail in the next slides. We have standardized a lot of our workflow to minimize variation. We have designed our education around the areas of current QI projects so that the two are linked. We have focused on what adds value to the patient. We have clear plans for sustaining and tracking improvement, and the process owners are held accountable for that. For example, for every project we do, we have 30, 60, and 90-day audits to make sure we're implementing correctly and tracking issues or problems. And finally, problem solving is encouraged at the front line rather than dictated by the leadership. So this is our readiness board, which is part of our DMS, or daily management system. It is updated daily and the team huddles around this board every morning. It gives a quick overview of what is happening in the lab on the day and any situations that we need to be aware of, such as staffing or equipment concerns that could affect our workflow for the day. This is our metrics board where our data is posted and discussed every week. And as you can see, this is pretty low key and it does not require a lot of dollar investment. Metrics need not always be fancy run charts. This is a simple way we track our start time for inpatient echo, which was a project that we did last year. Our goal was to start 2 echoes by 8 a.m. every day. And every day we achieved it, we marked it green. And if we didn't, it was shaded red. And then we write down the reason why so that we can track and the barriers and then find an intervention or solution for them. Studies have shown that educational interventions can improve quality in the lab, including reproducibility of EF measurements. For this reason, we created a testing environment in our PAC system, and we have used systematic cycles of testing and training to improve variability in EF measurement in our lab. So we measure EF with the area length method, and what you see, the table here shows the various phases of our project and the variables that are used for computing the EF by the area 5-6 area length method. Phase 1 was baseline performance. Phase 2 and 3 were after group education and individual one-on-one training. During phase 4, we provided real-time feedback to sonographers and assessed if improvement was sustained. 19 sonographers participated in this project, and we were able to improve the reproducibility in the LV size and EF measurements, as shown in that last row, and we were able to sustain the improvement at 6 months. So we've used this as a prototype, and now we have done the same for clinical implementation of 3D EF, and we are currently rolling out strain for implementation throughout the lab as well. One way for echo labs to integrate QI into their workflow is to create standard work processes. So in our center, we showed that by creating standard work around pre-discharge echocardiograms after congenital heart surgery, including the use of sedation and focused imaging protocols, we could improve the quality of studies from a baseline rate of optimal imaging of 48% to up to 73% after intervention. In fact, we have created standard work for our daily workflows. This is work that we created as a part of a project to standardize communication and on the inpatient side, as well as the workflow on the inpatient side. So every reader was doing things differently, much to the frustration of our sonographers. We were not able to turn around our echo reports in a timely fashion, especially the ones in the ICU that we wanted to be able to read them quickly enough so patient care management decisions could be made. So we came up with a number of documents to protocolize, if you will, how we would communicate during the day. And this picture that on the slide shows what we do first thing in the morning. So when I'm on for inpatient echo and I get a secure text and email just as I'm walking from my car to the hospital around 6:50. It has information about the team and the work for the day, as well as the specific echoes we need to plan in between the ORTEs, like, for example, an ECMO beam. So this helps us plan our day and deal with some very busy days in an effective manner and avoid chaos. For example, if we have an unusually heavy inpatient echo load, the clinic sonographers will go out to the floors before clinic starts and do one echo each. So the work is divided and less overwhelming. In other words, we try to match the supply to the demand. We try to provide a level load for the readers so that they're not sitting around waiting for hours for echoes to be done and processed and then bombarded by multiple echoes to read. So the goal is to have a steady cadence of work. And that's somewhat hard to do in the healthcare situation because you really don't know what you will get every day, but there's certainly a lot we can do to make things better. And of course, there are competing demands on us all the time. And how do we know where we should focus? One thing we've tried to do is focus on efforts that add value to the patient. Like most labs, we retrospectively correlate our echo diagnosis with surgical reports to assess diagnostic error. In June 2015, we took it a step further and we started a preoperative image review process. So this is a weekly known meeting attended by the imagers and the fellows, and the group reviewed the surgical cases for the upcoming week. They ensured that all imaging was complete and created a summary that went into the chart. One of our fellows looked into the incidence of diagnostic errors pre and post instituting this process, and we found that we could significantly decrease the errors. We reviewed about 1,400 cases over a 3-year period, and our error rate, overall error rate, dropped significantly, and certainly the moderate and major errors were significantly different after we instituted this process. And we showed that this type of second review imaging of the imaging could prevent about 20 errors from reaching the patient by doing this. Seeing the value of this process, we have now moved this review to occur when the patient is being presented for surgery. We have tried to do the opposite of the top-down approach and instead engage the sonographers and readers as frontline providers in QI and problem solving. We have a tiered system for sonographer professional advancement and participating in QI activities as part of the job description at every level. The sonographers are currently involved in projects which they have conceived and are implementing with very little oversight from me. This is the problem-solving section of our board. So there, you can see there that we have what's called quick hits, which by definition are problems that we can solve in 3 days and using resources within the department. And the others are more long-term projects. Each of them has a process owner as well as a target date for completion. The shaded green circles are called Harvey balls, and they indicate the phase of the project. Are we in the assessment phase and identifying our intervention? Are we implementing our interventions? Are we auditing and following up after the implementation? And finally, completion. So it's very similar to the PDSA cycle. And again, it is encouraged that we keep finding problems or failures to constantly improve upon so that we become more and more of a high reliability system. So to again summarize these points, the healthcare climate is increasingly value-based, and it's important that we encourage a culture focused on quality in our teams. We have certainly found that using the basic principles of QI science to guide us has been very successful. And as a bonus for our lab, this has resulted in MOC points for the physicians, as well as increased scholarly productivity for our team in the form of abstracts and papers at ASE and other conferences. So I'll end with a few thoughts on where we are and should be heading next. I think there's an opportunity for us in ECHO to collaborate and learn from each other. Certainly that has become very apparent with collaboratives, QI collaboratives such as the NPC QIC, which is for the single ventricle patients. The Adult Congenital and Pediatric Quality Network is one mechanism where participating sites can submit data and not only compare themselves to peer institutions, but also through webinars and learning sessions, learn from each other. The American Society of Echo is developing or has been developing the Image Guide Registry with the goal of tracking and reporting imaging-specific quality measures and creating benchmarks. And the Society of Pediatric Echo, or SOAP, under the leadership of Meryl Cohen and Shobha Natarajan from the Children's Hospital of Philadelphia, has recently launched a multi-center project looking at diagnostic errors in echo for congenital heart disease. And hopefully we can learn more from that project to know what type of errors can occur and what different institutions are doing to prevent those errors. Through data such as these, it may be possible to study quality metrics in echo, especially in relation to patient outcomes, because that is not something that has been very clear so far. I think leveraging technology is very crucial in making QI less cumbersome and involving less manpower. So there are certainly studies that have shown that using facilitated echo report with a set of rules or diagnostic guidance can detect and help with the real-time correction of discrepancy in the echo report. In addition, similar guideline-based decision support embedded in the EMR, for example, has been used for appropriate ordering of echoes or in the radiology side, CT scans and MRIs. And point-of-care tools such as the AUC app can help in improving the appropriate utilization of echocardiography. Using automated software for measurement could improve reproducibility as well. And that's something I think it's very important that we collaborate with our industry partners to develop these easily usable tools and not only develop them, but then make sure that they're available to a larger audience beyond leading academic centers so they could be implemented more nationwide. And finally, the advent of artificial intelligence could change our world for the better as far as improving our workflows and accuracy as well. And of course, this is a small portion of our team, and none of this would be possible without teamwork and efforts of each and every person. as well as the support of our Heart Center leadership. And I'm probably going to get into trouble for doing this, but special shout out to Rita France. She's hiding in the back on these pictures. She's our technical director and has been a wonderful team leader and role model, and encouraging each member to be more. So I'll thank you for your attention, and I'm glad we got done a little bit ahead of time so that we can have time for questions, because I'd certainly love for this to be an interactive session where you can share some of your thoughts, and I'll be happy to share more about our experience as well. Thank you.
Okay, thank you very much. And at this time, we'll begin the Q&A session. From IAC Echo, I'd like to introduce Katie Gibson, our Director of Accreditation. She will be assisting with the Q&A session today. Katie, would you like to start us off?
Absolutely. Thank you, Kelly. And thank you, Dr. Parthiban, for that excellent peek into what Children's Mercy is doing to improve the quality of their patient care. I would like to start off with sort of a burning question that is also a question that we get often at the IAC. How do you approach resource allocation in terms of completing your QI projects? Do you have a dedicated person that handles this, a team of people, or is there a certain amount of time set aside for your technical director to work on these projects?
Yeah, and that's an excellent question, Katie. And I think it's what we all struggle with, not just in Echo Labs, but everywhere else, because we have limited resources and just so much more to do. So the way we've tackled this is in a couple of ways. Technically, on paper, we do have some dedicated time. So our technical director has some protected time, including, and then we have some protected FTE, like a 0.5 FTE for QI and education. However, I will tell you that they often get pulled into clinical work. So our strategy has been more the approach of divide and conquer. So like I said in my slide, we have almost every sonographer and several of our readers are involved in some sort of QI project or endeavor in the lab. So by dividing up the work, you can often find some time during the course of the week to do whether it's data gathering or education, whatever we need to do. So we have found that approach is very successful. I'm not saying that we don't need resources. We do, but we can, I think, get around some of that scarcity by working well together in our team.
That's some really great points. What about those facilities that are single practitioner or only have one sonographer, or even just a single practitioner who's scanning their own patients? How can they apply those QI rules?
I think it could be applied in any setting, and obviously the scope or scale of what you would do would be different. And in my mind, a single provider or a provider that has a single sonographer, I think they go to the drawing board and go through that improvement model, like the way I showed before, and say, what is something that we recognize as a problem that we could change? And taking small steps and doing, making small changes and assessing is a good way to do it, because anytime you try to do this enormous project with lots of data collection and you don't have the resources, then that is bound to fail, because you start with this lot of energy and enthusiasm and quickly find that you're not able to go through with it, and that results in a lot of disillusion. So you feel like you don't want to pursue it any further.
Right. So clearly, with your project, a lot of what you found that needed to be improved was communication for your throughput. We noticed that you mentioned that you have 11 sites. Do your team members at all those outside clinics participate in the daily huddle as well?
The daily huddle, they have their own huddles. So it depends. In our main site, which is where a number of the sonographers are there, we do a huddle near the board at our main site. And then we have a few satellite sites where we have more than one sonographer. So they do their own huddle. And I think that's important because your workflow at each place is different. And it makes sense to do it independently. However, they are involved in all of the global QI projects. For example, the echo reproducibility project that I talked about, it involved every sonographer in our system. So, and then when we are doing the 3D EF, we involved everybody. So because we believe that we want to invest the time in all of our sonographers and readers, in whether they're in a satellite institute or not, so that they feel engaged and they're learning new things, and that keeps them very interested and continue to be a really good team member.
Thank you.
And one thing I'd say with QI too is what works in one place doesn't work elsewhere. So what works at Children's Mercy may not work at Cincinnati Children's, for example. And that's why you come back to that drawing board, like I say, and first thing you do is assess your situation, assess your environment, and then go on from there.
Great. I kind of in regard to our quality improvement requirements at the IAC, we do have teams where the sonographers will be reviewing interpretive quality with the doctors. What do you think is the best approach for a sonographer to take who has found an issue with interpretive quality? They may be intimidated to actually speak up about this. So do you have any suggestions or thoughts?
Yeah. Well, that's a great question. And I recognize that is a problem. And for a good team to function, and that culture of safety and quality I talked about, there should be, you should encourage finding problems, right? I mean, the environment should be such that anybody who finds an issue speaks up. And I think we have done that in our lab. I am so thankful to the folks I work with. They are just amazing. But I will, initially it may be intimidating, but I would suggest to the sonographer to just go and show that information and present it in a way that is, not judgmental, and most often that will be taken well. I mean, all the time. If I say in my report, arch branching not shown, and it's there, I am sure to get a text saying, with the image number and the frame number, and say, hey, I showed this. So we encourage that, and I think that's how you improve quality. And it's up to the leadership to foster that culture in the team.
Yes, so true. This is a really interesting question. Have you implemented any QI initiative to help make your reporting more uniform for common congenital lesions, such as bicuspid aortic valve or VSD? I know that people are training in different facilities and then coming to you as an attending, so you're going to get nomenclature that's all over the board. Have you implemented any QI initiative within your lab?
We have not exactly, designed a QI project as such around it. We do have some macros to use for certain congenital heart lesions, and we will use them. And I think we try to stick to an overall conformity, but in my own mind, I don't want to micromanage our readers too much. So I would say that we do have some variations, but we try to keep things generally uniform. But to specifically answer the question, I don't have experience of doing a project for that problem as such, and so I have no particular pearls of wisdom to impart, I guess.
Well, thank you for trying. So how do you determine what your balancing measures are when you take on a large project like what the example that you gave?
Yeah. So for balancing measures, for our project that I talked about, where we looked at, quality. So we did surveys of the readers and the clinic staff. So for the readers and the clinic docs, the specific questions were: are you finding any issues with incomplete echoes, or the sonographer forgot to get some images, or something like that? And then for the clinic staff, it was: is the echo project affecting affecting your workflow? So it can be as simple as a questionnaire on SurveyMonkey, but it could also be more involved. I mean, I guess if we wanted to, we could have chosen a random sample of echoes and had them judged for completeness or quality, and assessing did they answer the clinical question that was asked. So we chose not to do that. We chose more to poll and get a survey, which is obviously qualitative, but nevertheless helpful.
We have had a few questions regarding the lean training. Do you have any references or advice on how to approach your own training? Any examples to emulate that lean training?
I have, like I said, received most of this training from pretty much all of this training from within the hospital resources, and some of it was gained from doing some field trips to actually even some factories that employed the lean the lean mechanism. There are several sources for learning about quality improvement, and I think there are courses available. I can offline try help the person with some list of resources, but there are certainly courses that you can take online and learn more.
That's it. Great, gracious of you. This is kind of an interesting one too regarding contrast. Contrast has been pretty well demonstrated and documented to significantly impact the quality. Do you incorporate the use of contrast at Children's Mercy?
We haven't. We are pretty much entirely a pediatric lab. There have been some studies looking at the safety of contrast in pediatric patients, but it still is not a very widely employed technique, not as much as the adults for sure. And so, no, I do not have. I know there are some studies ongoing looking at the safety and efficacy of contrast, but we are not using it at CMH at this time.
I see. And kind of going back to your QI project that you spoke about, and this is a really nice question. In these very high volume labs, how do you balance and streamline efficiency, and balance that with also training sonographers and fellows thoroughly?
Yeah, I mean, I think it's something we struggle with a lot here as well, and again, I would say there's not a cookie cutter answer, but with each situation, you've got to achieve some sort of happy medium, if you will. So, for example, our fellows, and if it's a very busy, high volume clinic day, we will typically ask them to follow the sonographer on the inpatient side, and so I recognize that's an important issue, and it's difficult to address. But at the same time, I think by looking at your work carefully, you can certainly find solutions that can try to balance the two needs.
I see. And I have a personal question about your QI project. Did you find a correlation after you improved the efficiency of your wait times, and your lab operations, did you find any correlation in the quality of the imaging, or, and I guess as well as the happiness of your staff? Did they feel less pressure to push echoes through?
Yeah, I mean, we didn't in a quantitative way look at quality. Like I said, one of the balancing measure was would we lose quality by emphasizing efficiency? And at least in a qualitative survey-based fashion, we did not find that. I think as far as the satisfaction, I find that this sort of planning for the day by itself helps. And I don't know, maybe I have a bunch of wonderful people I work with and they seem to be happy all the time. But I think the good teamwork, pitching in for each other and trying to go in knowing what you're going to do for the day seems to help. And we make sure that we, as a Rita France, who's our technical director, and I mean, we make sure that we listen to concerns and try to resolve problems as quickly as we can. But also empowering the sonographers themselves to find solutions has been huge because, they find an issue and it's not like, okay, something's not working somewhere. They don't, it's not a big cycle where you have to go and you report to one person and that person may keep it on their desk for a week or whatever. We try to be very proactive about at least taking care of those small things that can make your day difficult. We've focused a lot on improving efficiency. So one of the things is sonographers had to go from one floor to another to put in their numbers. We put in reading stations in every floor, and that was a huge satisfier. So they can just go to that station and put in their numbers, and they're not wasting time shuttling back and forth. Small things like that, I think, make all the difference.
I agree. Thank you. I'm going to pass it back off to Kelly now. Thank you so much for that great Q&A session.
Thank you.
Okay, thank you, Katie, and thanks again, everyone. And a very special thank you to Dr. Parthiban for her presentation today. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session and also be available from the IAC webinar portal for 3 business days. On the left side of the My Account page, you'll click on Webinars, look for the title of this session, Continuous Quality Improvement in the Echo Lab, How Do We Walk the Walk? Beneath this title, you will click Review Event. On the left, select the Evaluation tab, then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen and anytime thereafter through the CE transcripts section on the My Account page. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.